Continuing education credits for physicians and other healthcare professionals is provided by VCU Healthcare Continuing Education. Check out cribsiders.vcuhealth.org for more information.
The Cribsiders podcast is for entertainment, education, and informational purposes only. The views and statements expressed on this podcast are solely those of the host.
Welcome back to the Cribsiders.
Woo!
Love the energy. Justin Burt tonight, joined by Dr. Sam the Chew Man Mazer and our producer, Dr. Lauren Lattingham. Lauren, great to have you back. How's it going?
It's going well. I'm excited to be here.
It was great to have you. This was a great episode. We had a wonderful guest tonight, Dr. Kevin Flanigan, here to discuss muscular dystrophies. But before we dive into the content, hey, Sam, can you remind us about the show?
Sure, Justin. We are the Pediatric Medicine Podcast. We interview leading experts in the fields to bring clinical pearls, practice-changing knowledge, and answering lingering questions about core topics in pediatric medicine.
Today, we had a fantastic conversation with our guest, Dr. Flanigan. Dr. Flanigan is an expert in the field of neuromuscular disorders. He is currently director of the Center for Gene Therapy and the Research Institute at Nationwide Children's Hospitals, which developed the first FDA-approved gene therapy to treat Duchenne Muscular Dystrophy. He teaches us when to think of muscular dystrophy as a diagnosis, how BiPAP can extend the lives of patients with Duchenne's, and what the latest gene replacement therapies have to offer.
So without further ado, let's get to it.
Registry reports disclosures including clinical trial supports from Sarepta, Diane, Avidity, Ultragenyx, and Solid, and advisor compensation from Armitage, Locarnabio, Cephone, Encoded, and Insmed. We don't mention any brand names and include evidence-based discussions based on peer-reviewed data only. Welcome, Dr. Kevin Flanigan, to the Cribsiders. We're so excited to have you. Welcome to the show.
Well, thanks. It's a pleasure to be here. Looking forward to it.
I mentioned earlier, but we're a pretty informal group. Is it fine if we call you Kevin throughout the show?
Sure, of course. Yeah, that's fine.
All right. Justin, Sam, or Sammy, you can come up with nicknames for us throughout the show. Informal group. We are excited to meet you. Our listeners are excited to meet you. And we'd love to start with just hearing maybe a one-liner introduction about yourself, of who you are, things you're interested in, and maybe something that you do outside of medicine.
Sure. So I'm the director of the Center for Gene Therapy here at Nationwide Children's Hospital. I see patients in clinic, and my laboratory is very interested in approaches to gene therapies for muscular dystrophies, particularly approaches that might lead to the next generation of gene therapies. What I like to do outside of this is really, probably play the jazz trumpet. That's my favorite thing. My undergraduate degree is in music way back when, and I picked it back up about 10 years ago and trying to get a little better every week. Not very well, but trying to.
I love that. Good. I feel like it's tough to keep up a musical instrument like post-medical training, and yeah, I'm inspired by the people who can manage to do that, especially jazz trumpet. I feel like there's not a huge, I don't know, where do you play in a quartet? Do you play in a?
Well, no, there's a really great jam session here in Columbus downtown that lets any duffer in. So I go there. It's my 90 minutes of Zen every week.
Amazing.
Yeah.
Sam, Lauren, you want to do the next question?
Yeah, sounds good. So then our next question is, what's the best advice you ever received as a learner or as a teacher or in your career?
Well, I think the best advice relevant particularly to the pediatric population is if the transaminases are elevated, make sure to check the CK as well. It's certainly relevant to diagnosis of muscular dystrophy, and it's quite important.
I think that's good advice really for life more broadly, too.
Right.
I think it has universal application. I love this. I think we're going to make it a quote.
Well, as a muscle doc, I think everybody should just get their CK tested once in a while. It's a good tune-up thing.
I remember I had an ED doc in residency who was like, if you ever see a kid like in the ED in clinic in a mall, check their glucose. I've seen it. Just anytime you run into a child, check their glucose.
Right.
These are great kind of, I think, life pearls, not just medicine. And that's what we're all about on the Cribsiders.
Hey, Cribsiders listeners, it's time to tell you more about Freed. So Freed is an AI scribe that listens, transcribes, and writes medical documentation for you. Gabby, a family medicine physician, and Erez, a computer engineer, came up with Freed, a solution that could help alleviate the daily burden of overworked clinicians everywhere. And for Erez, selfishly, it would mean that he could spend more time with Gabby, who is spending nights, weekends, and holidays updating medical documentation. Freed turns clinicians' daily workflow into accurate documentation instantly. There's no training time, no onboarding, and no extra mental burden. All the magic happens in just a few clicks, so clinicians can spend less energy on charting and more time on doing what they do best. So today, more than 4,000 clinicians and their spouses have fallen in love with Freed. Freed listens, prepares your notes, and writes patient's instructions. Freed even learns your style over time, just like a human scribe. Most importantly, it is HIPAA compliant and takes 30 seconds to learn. So you can try Freed for free right now by going to freed.ai, that's FREED.ai, and listeners of Cribsiders can use code CRIB50 for $50 off their first month. Again, that's code CRIB50 for $50 off their first month.
But I'm excited to kind of dive. I mean, this is great. Let's build on this and kind of maybe dive into some content. And Lauren, you want to start us off with our case from Cashlat Children's Hospital?
I would love to. And I can just say now I will check hemoglobin A1Cs, lipids, and then I'll just throw in a CK there every once in a while as part of my routine panel. I love it. But in terms of getting back to our case, we have a 4-year-old boy who is seen in your office because his parents have noticed that while running around on the playground, he can't keep up with other children his age. His history is notable for delayed walking at 18 months and tiptoeing per parental reports. They also note that the patient sees a speech therapist for speech delay. On your exam, you find 4 out of 5 strength in the lower extremities bilaterally with diminished patellar reflexes, bilateral calf hypertrophy, and gluteal muscle wasting. Upper extremity strength and reflexes are intact. So we'll start really broadly here. So hearing about this case, what makes you think that you should be concerned about this muscle weakness on the history and physical, and what's on your differential more broadly?
Well, so, the differential is kind of 1, 2, and 3 to begin. There's certainly other things we should think about with it, but really the dystrophinopathies and specifically Duchenne muscular dystrophy jump right to the front of the list. This is the classic age for when diagnosis becomes obvious to parents. It's historically, it's been diagnosed in this age at sort of 3 to 5 years old. Very commonly because children have a bit of developmental delay, walking delay, but in those toddler years start to separate from peers. They're running around slower and do this toe walking. And it's not at all common that parents come to us at the same time and describe children having difficulty getting up off the floor using the Gowers maneuver, which we have all been taught in medical school. Now, the Gowers maneuver is not specific in any way for DMD. Proximal limb weakness is not specific. There are other diseases, the sarcoglycanopathies in their severe form. The limb girdle muscular dystrophies can look like this as well. But numerically, by far, this is the most common cause to have it with the gene encoding the dystrophin protein, resulting in Duchenne muscular dystrophy. So we don't discard anything, but the first thing we do with this is test the CK. And if there's an elevated serum creatine kinase, then until proven otherwise, it's a Duchenne muscular dystrophy.
And you mentioned some of the other items on the differential of some of the other dystrophies or just other myopathies, really. And can you talk about what are some of the other common muscular dystrophies? How do they differ in presentation, either by epidemiological factors like age of presentations, or how do you put them into buckets for someone who's just presenting with pretty significant muscle weakness? Or even kind of, what other presenting factors make you start thinking about these?
Yeah, part of it is the age at onset. So, there's the congenital muscular dystrophies. Broadly speaking, we lump things into the congenital muscular dystrophies where the symptoms are present at birth or within the first year or so of birth, where those are obvious. And that's not the case with Duchenne dystrophy. It is true that you can look at Bailey scores, and if you look at enough Duchenne boys, there are some delays there, but there's a real different presentation from kids who are frankly weak with profound hypotonia, elevations of CK, and these are the congenital muscular dystrophies, sometimes associated with, for example, brain malformations or other things in their most severe forms. Then there are the congenital myopathies, things that are not very common. Each is an ultra-rare disorder. Things like the Nemelin myopathies, which have at least 8 different genes encoding that are associated with it, or X-linked myotubular myopathy, where the presentation is very severe in the first months of life, often in the ICU. They're NICU diagnosis for many of those. There's not a lot of diseases that have this kind of category where you have years of slightly delayed development, but pretty normal development. And at this age range of 3 to 5 years old, you start to have weakness. I mentioned the limb-girdle muscular dystrophies. In the old days, the older books used to describe the function of the dystrophin protein binds to the sarcolemmal membrane, where another complex of proteins called the sarcoglycans are located. And those sarcoglycans are associated with, each of those are associated with the potential muscular dystrophy syndromes as well. Some of them can mimic this early onset of Duchenne muscular dystrophy, but numerically they're much less common. There's a reason for that.
Yeah, what are some of those reasons? I think, what are, why don't we think about those as often?
Well, so there, as an X-linked lethal disorder, I want to say historically lethal disorder, that the classic Duchenne phenotype of dystrophin-related disease would preclude living and having a family and reproduction and so on. So it's X-linked lethal in its severe form. And by Haldane's rule, that means that 1/3 of the time it's a de novo mutation. And the reason there are so many de novo mutations and so many mutations in the DMD gene is the size of the gene. It is the largest gene we know of, the largest locus we know of in the human genome, about 2.4 million bases on the X chromosome. So it's a huge target area for mutations. And even within those areas, there's some hotspots that seem to be particularly prone to rearrangements, kind of the deletions that are most commonly associated with the gene. So in comparison, I mentioned some of the limb-girdle muscular dystrophies with sarcoglycan mutations. Those are quite small genes. They're tiny target areas, as opposed to this huge locus that can be the site of many different mutations.
So I think, we're starting to get a little bit to the intricacies of some of these muscular dystrophies. So we should probably back up ever so slightly and talk about what is a muscular dystrophy, what is dystrophin in and of itself, and then we can start getting a little bit into the gene pool and where this stuff ends up. So if you wouldn't mind just taking us through dystrophin as a protein, dystrophin as a disease process.
Sam, I apologize. That's a risk, what's the thing when you have a hammer, everything looks like a nail. This is what we do day in and out in the lab, so I apologize about that. You're absolutely right. So, dystrophin is it's a critical protein in muscle, and it binds at one end, at the amino terminus, the front end, it binds to the cell skeleton, actin. And at the carboxy terminus, it binds to the membrane through this whole complex of proteins I mentioned earlier. And in between those two binding sites is a region that becomes very important when we start to think about therapeutics for it, is this long we call it the central rod domain that consists of these spectrin-like repeat elements that are have a particular structure and extend for the entire region. The common metaphor for what dystrophin does is it's a stabilization of the muscle membrane. So if you think about every other cell in your body, right? Nephrons, neurons, osteocytes, these don't get distorted by movement the same way that muscle does. So unlike every other cell in the body, say nephrons or neurons or osteocytes or anything, these are, the muscle fibers lengthen and contract continuously under force. And in the absence of dystrophin, if you don't make dystrophin, that contraction, that distortion of the muscles fibers results in really visible tearing under an electron microscope of the muscle membrane, friability of that membrane. And what happens is we can measure the CK that leaks out of those. That's what we're measuring. It directly leaks out of fibers. And things leak in, primarily calcium that activates calcium-activated protease and so on. The upshot of this is, though, that muscle fibers deteriorate. And we all, all of our muscle fibers deteriorate. If I go out and try to run a 5K tomorrow, I would have muscle fibers deteriorate, but we all have regeneration capacity of our muscle from satellite cells. So all of us have that degeneration-regeneration cycle, but in boys with Duchenne dystrophy, and it's boys because it's an X-linked disorder, in those boys, the cycle is continuous and accelerated, and each time you go through these cycles, there's inflammation and fibrosis. There's scarring of muscle that lays down. As that occurs within muscle microscopically, sort of grossly, what we see is weakness of muscles. And if we look at under a microscope, we see these chronic and severe myopathic changes that consist of scarring, fat, and fibrosis of the muscle. Those pathologic changes are what we term dystrophic changes. So the muscular dystrophies, with the rarest exception, are disorders that cause those sort of pathologic changes in muscle. So fundamentally, that's what dystrophin does.
One of the questions before we move on, still focusing on kind of the epidemiology, it's X-linked, so we see it in males. Can we ever see dystrophic symptoms in carrier females? Is that something where if the X-linked is in a carrier female where we see symptoms?
We do. And, the most common, this is rare, but we see a whole range of symptoms, actually. Many carrier women have mild symptoms of muscle aches or exertional myalgias. It's not at all uncommon to talk to a mom and you say, well, tell me how you did in high school gym, or did you play lacrosse, or did play sports, play soccer? And it's not at all uncommon to say, yeah, I used to have a lot of cramping and muscle aches with that. And we see that as the most common presentation of this. In the old days, we used to check, before we had this great genetic testing, we used to just check a serum CK in mom. And they usually, with about a 70% specificity rate, there would be, you'd find mild elevations of the CK. Not the CK elevations of 50 to 100 times normal we see in Duchenne, but mild elevations. So that's a common presentation. But there are women who have actually much more pronounced manifestations, including women who are as affected as boys. They are indistinguishable. The typical mechanism for that, it's usually attributed to skewed X inactivation in muscle. We test for that in blood. It doesn't always reflect what's going on in muscle. There are other examples. There's the rarest cases where a girl has been found to have be heterozygous for 2 mutations or a few other things. But more commonly, we see a range of this. What we consider really classically symptomatic carriers are women who have a range of severity. It can range from Duchenne to more Becker-like to just cramps and muscle aches. And then there are women who have no symptoms whatsoever. But we do see it.
Awesome. Well, we've really focused on the skeletal muscles,
Right.
But what are some of the non-skeletal muscular sequelae of dystrophinopathies?
So really the one we worry about is the heart. Cardiomyopathy is really the most important of these. We have typically, or historically I should say, we would view cardiomyopathy as being measured by systolic function, by ejection fraction, as something we typically would become concerned about at 9, 10, 11 years old. But now with modalities like a cardiac MRI, where we can actually look at the degree of fibrosis of the myocardium and measures of late gadolinium enhancement, for example, on MRI, we can see that there is, in fact, the cardiomyopathy actually presents somewhat earlier. We can see it. So we typically start to make sure boys have an echocardiogram by 6 to 8 years old. Depends on the clinic. There's good meaning people who view the data a little differently elsewhere, but usually by 8 to 9 years old, we try to have boys on ACE inhibitors, particularly as something that helps with, seems a slow progression of cardiomyopathy. So the heart is the main one. Most of the other sequelae we see, I should come back in a moment to the brain. I'll come back to that, but in clinical function, most of the sequelae we see are really related to after loss of ambulation. We can see scoliosis. That is a skeletal muscle problem, but we see scoliosis and diaphragmatic involvement. And historically, the mortality has been due to cardiac or cardiopulmonary, cardiorespiratory failure. The other place, though, dystrophin is expressed is in the brain. And I keep talking about this one version of dystrophin that's in muscle. There's actually at least 7 isoforms of dystrophin, some of which are expressed in brain. They all share the C-terminal portion of the protein. The entire function of all of those is not known, but some mutations, particularly those mutations that affect the brain isoforms, can be associated with some cognitive dysfunction, anxiety, and other behavioral things, and some evidence suggesting a higher incidence of autism in some of those patients. The exact function of it isn't clear, though, and the degree of those involvement does vary kind of patient to patient.
Awesome. So that's a fantastic summary, actually. So we know now why we see it in striated muscle, cardiac muscle to go with. We're talking about the brain here. We've actually been teasing this diagnosis for a while. Our intro sentence was all about CK. Advice is all about CK. So let's go back to clinic here. So we have this 4-year-old who's coming in with relatively classic symptoms, as you mentioned. So what's kind of the general workup for muscle weakness in this type of patient? And then we'll talk about diagnosis in a second.
It really all starts with CK, and actually clinicians should know. I mean, when I started the field, it was we didn't even have, when I first started seeing patients, we didn't really have a test that could detect nearly all mutations in the gene. And we had ones that had about a 60% sensitivity that were commonly used. Now we have extraordinary tools for diagnosis. And in fact, because of the availability of some therapies, there are sponsored programs sponsored by companies or sponsored by some of the patient foundations where any patient with an elevated CK, we can do a complete analysis, not only of the DMD locus, but all of the other known sort of muscular dystrophy mimickers of it. So it's spoiled it. We like to think, us old timers like to think we're exquisite diagnosticians at the bedside and so on. It really has changed, and everyone should know this. If you have a patient with a CK, you can get at essentially no cost, or insurance does pay for them as well, you can get panel tests for all of the muscular dystrophies. So that's the number one thing. CK followed by genetic testing.
And to that point, if let's say let's say I'm Justin, because I am, and I am, a lowly primary care doctor in the urgent clinic, and I see a patient like this, and I'm like, I think that the strength is 4 out of 5, but it's tough, and maybe he has some calf hypertrophy, but it's tough to say that that's truly, clear on my differential, and I certainly didn't, check his gluteal muscle wasting. But I'm at least, smart enough to know, or I'm thinking about a CK. I did a CK and it's elevated. Is there a pathway that you think care providers should be thinking of? This is a myositis that is causing, muscle weakness. That could be a lot of things, including the congenital, but also acquired things we haven't really talked about. Versus when this is like on the pathway of I am thinking about a muscle dystrophy and need genetic testing, so that I'm not ordering, genetic testing on everyone that comes in with myositis. What kind of helps you guide to that framework?
Well, that's a great point. And, I skipped over, I jumped, as you pointed out, to muscular dystrophy and genetic muscle diseases. What really helps me distinguish in clinic acquired or particularly inflammatory acquired myopathies, things like a juvenile dermato, let's say, is really the course. And it's really this generally slowly progressive course. Of course, what I didn't mention was the family history. We were talking about 1/3 of these being new, but 2/3 of the time they're derived, inherited in the maternal line. So we always begin first with the question, is there cousins, are there uncles, or does anyone else have the family history? An excellent family history puts you right in the category right away. In the absence of that family history, though, the sort of clinical course, I think, is the most helpful portion of this. We do look for changes that are of course, the exam, we look for things like skin lesions that would go with dermato or other things. But the CK is super helpful, because the CK for most acquired diseases, although it may be elevated, and they're ranged into 1,000 or 2,000, let's say in some of the cases, we're talking with boys with Duchenne, they walk around with CKs 14 or 15,000. These are quite elevated. And in fact, several times a year, we get people who've been brought into the hospital with an assumption that they have some sort of rhabdomyolytic event, right? They presented at some point to a hospital, and the CK is 5,000. And understandably, people are cautious about this and think about this and want to bring them in for hydration or other things. But when the CK does not normalize, they often are referred to us. I will point out, while I'm saying all this about CK, it's an imperfect biomarker. It can change in the presence of a dystrophinopathy. A boy that I mentioned might be around at 15,000. If he's spent the week laying around the house for whatever reason, he's playing video games, might drop to 8,000. He goes to his cousin's birthday party and plays in the bouncy house, might go to 24,000. This range, it's really an activity-dependent range. I think where we get into a little more subtleties of it is in these milder alleles, the ones that are associated with Becker muscular dystrophy, where we may see patients who have CKs in the 2,000, 3,000 range. And then it's really very important to understand the history. How did this present? Was there a history of development of motor delay, of delayed walking and things? Has this been a progressive disorder, or is it something that developed over months?
And I'm just going to ask a follow-up question for a second. So the CK we talked about is our big screening test. I was curious, it sounds like it has a high sensitivity. What is its negative predictive value? If we see a normal CK, or we're like, we are good, should we go somewhere else, or are there patients that we should still be thinking about muscular dystrophy?
Yeah, for Duchenne muscular dystrophy, it's negative predictive value. Gosh, I should know the numbers, but I think it's we consider to be essentially exclusionary for Duchenne dystrophy. I got to go a little bit in the weeds, though, for a minute here. So we haven't talked about what Becker muscular dystrophy is, right? So Becker muscular dystrophy, the textbooks define it as a sort of a later onset, same pattern of weakness, also a limb girdle pattern of weakness. But Becker muscular dystrophy is a term we use for any dystrophinopathy that's not Duchenne, right? These are the people who stop walking at 20. There are men with these versions of dystrophin that allow them to walk to 40 or 50. In fact, we know of some alleles that people are walking at 80 years old with. They still have elevated CK and have problems along the way, like cramps and myalgias and some muscle symptoms. So all of those things fit into the Becker category. What we're seeing now, because of the widespread availability of genetic testing, are more and more alleles in the DMD gene that are truly either asymptomatic or paucisymptomatic. So, and it's good for clinicians to know about this. We see an increasing number of parents, for example, of boys who come to us because the parents had, as one example, preconception testing, and they have alleles in the gene that are not really associated with weakness or even elevated CK or only mild elevations of CK. So we're collecting these under one of our NIH-funded studies. We're at boys who have a CK in the 500, 600 range when they're kind of a day-to-day life, yet they have mutations in the gene. These are not Duchenne muscular dystrophy. They're some kind of the mildest version of Becker muscular dystrophy. But these are turning up all the time now. We have developmental delay. We just saw a patient, because of HIP, I won't give all the details, but we saw a patient in clinic today who had a mild delay, had a microarray, and had a very interesting variation in the gene with a completely normal CK. It probably will have no implication for him in his life, but parents are coming and saying, what does this mean? So I think, in answer to your question, I think the sensitivity for classic Duchenne is approaching 100%. I've never seen a boy who had anything resembling a classic Duchenne progression in phenotype, sort of losing the ability to walk by 12 or now with steroid treatment 15 years old or so. Never seen a boy with that who had a normal CK.
And that's perfect for us, just as you said from the beginning, hey, check a CK. It sounds like this will at least be a very, very good screening test when it comes to DMD. So we kind of talked about, just to kind of summarize a little bit, from your perspective, when we have these patients come in, we test a CK. If it's an elevated CK, if we're looking for Duchenne's muscular dystrophy or Becker's, which we'll get into in a second, it's genetic testing kind of straight up. As far as in between, we talked about, Justin had mentioned trying to differentiate between something like myositis or a different disease process. And it sounds like that's both based on your history, physical, the rest of the disease process. And then you get to kind of I don't want to say diagnosis of exclusion, but over time you realize that it's not something that's more acute, and instead this is something chronic. Am I correct there, or is there any in-between test that we missed?
No, I think you're absolutely correct. There are certainly things, Duchenne dystrophy, it's a limb girdle pattern of weakness. You've described in this case a pelvic girdle as a presentation for it. There are other diseases that can do that, other syndromes. For example, acquired myasthenia gravis, right? Autoimmune myasthenia gravis can present in a limb girdle pattern. Typically, there might be other features in the face or eyes or things, but it can present in this pattern. But it is a different course. It doesn't have this kind of course to it. Same with the inflammatory myopathies, dermato or another form of polymyositis. One of the cautions we always have when we're using CK as such an important screening test is there are viral myositis. People come in with a viral syndrome. We take a CK and CK is quite elevated, and let's say in the 2,000-3,000 range. And in those cases, we will often get the genetic testing while retesting a CK sometime a few weeks later if it's in the setting of a really specific event. So we always like to point out that the transaminases, which colloquially we think of as liver function tests, are actually AST and ALT are released by muscle, and they track quite clearly with serum CK. So boys with Duchenne dystrophy who exercise their CK might double, their AST and ALT also might double. And because of that, it's not uncommon. We probably make one diagnosis a year in our clinic where a child had a viral illness, their enzyme, they had a metabolic panel checked, and because of those transaminases, they go through an evaluation that might even include, once a year we see one boy who's had a liver biopsy done unnecessarily. So it's good to keep that in mind. What we use clinically in those settings is we always recommend, in that setting, to check a CK as well. And GGT can distinguish. GGT is only released from liver, not from muscle. But it's just kind of good to keep that in mind, I think.
We've sort of really emphasized the importance of labs and blood work in these patients, and you sort of just touched on it. Is there ever a role for something like a muscle biopsy or an EMG, or has that become fallen out of favor because we have the ubiquitous gene testing now?
So that's a great question. I don't think there's a role for EMG in the setting you've described. Certainly EMG is useful if there's a suggestion of a family history of a myotonic disorder or other things you can still have use for it. Or we haven't mentioned motor neuron diseases. Of course, the things like SMA present much more quickly. And testing is readily available for those, has been superseding EMG for those. But muscle biopsy remains, I'm going to say, my most controversial thing, I think, of this podcast.
Right.
That there remains a significant role for muscle biopsy in the clinical practice of muscular dystrophy. So not routinely. I'll explain. We've recently just published a paper just a couple of years ago for what I think is a completely under-recognized mutational class related to this. So we have boys, I described this huge gene locus on the X chromosome of 2.4 megabases, 79 exons scattered across those 2.4 megabases. Those 79 exons, when they make the cDNA, is only 11.5 kilobases, right? So this is an enormous gene locus and a sizable gene, but that's a huge difference. This means that there are huge introns. We have exons that are 300 nucleotides and introns that are 200,000 nucleotides, right? Big mutational targets. And it turns out that in our practice, sort of 20 years of accruing some 2,000 patients in our big databases and genotype-phenotype database, in those patients who we have a clear X-linked family history, or we do a biopsy when we can't find any mutation in any gene, the great genetic testing we refer to tests coding region mutations. In those patients who have negative coding region mutations from the available blood tests, or they have an X-linked family history, every one of those patients we biopsy and establish do they have a dystrophinopathy. And in every one of those patients we found with a dystrophinopathy, it turns out that there's deep intronic mutations. And these deep intronic mutations result in inclusion of intronic fragments that cause the disease. They're not detectable by blood tests. You require a muscle biopsy to establish that this is a dystrophinopathy, easy to do by protein studies. And then you have to do this mutation analysis. We actually think the controversial part, as we put in the paper, is this could be up to 7% of all patients with dystrophin-related disease. That's controversial because the databases say they're not that common. But we have to recognize the way into most databases was the mutations you detected result in you going in the database. So that's one use of biopsy. The second use of biopsy we often find now is in the world of therapeutics, right? There's lots of new therapeutics that are coming out, and I'm sure we'll touch on them, but some of them are quite expensive. Some of them We don't know ultimately just quite how good they can make things. And we do see patients now with better genetic testing where the mutation cannot clearly predict whether or not some dystrophin is being made or not. So I actually biopsy in that clinical setting when we want to tell parents this is not a well-defined mutation. We don't know if your boy is going to be walking till 20 or 12 or 25 or 12. Why don't we do a biopsy and see if there's any dystrophin being made? These are mutations, for example, that might affect a splice site in a funny way, or might have an impact on splicing but haven't been proved to have that. And before we expose those boys to the significant risks associated with things like gene therapies, I feel it's necessary to know what the underlying sort of protein function is. That's not terribly controversial, although there not all places would pursue that. On the other hand, we have a kind of our clinic, my clinic particularly, is sort of enriched for patients who have unusual mutations where we're trying to understand the implication on disease and therapies for it.
So this might be a simplified question for
Yeah.
you kind of us generalists here. When I first made the assumption that if you have a mutation on the X chromosome in the Duchenne muscular dystrophy location, that is going to be consistent with Duchenne's in the sense that you are unable to make dystrophin and therefore have the more severe disease process. That sounds like that might not be true. So are there certain locations, and i.e. really certain positive gene findings on these tests that will indicate whether this will, quote, be a Duchenne's versus a Becker's, regardless of where it is on the X chromosome?
So it's not so much where it is fundamentally it is where it is on the X chromosome, but it's kind of where it is in the structure of the cDNA. So these 79 exons can be put together in one way and one way only to maintain a reading frame from the beginning, to translate from the beginning of the protein to the end of the protein. And I should add that about two-thirds, 65, 66% of mutations are deletions of one or more of these exons that cause disease, right? So these are pretty large scale. Most are not point mutations. They're these big deletions. So if you can imagine that there is only one reading frame to read from start to finish, and you snip out, your deletion is missing one of these exons, and if that exon absence now shifts the reading frame, right? We read in groups of three, codons read in groups of three. If we shift that reading frame, then you don't make the protein. But there are plenty of examples where you take out the exon next to it and the reading frame remains open, right? So an example would be a deletion of exon 50 shifts the reading frame and you make no dystrophin. A deletion of exon 50 and 51 maintains an open reading frame, and you make a quite functional protein, a Becker-like protein. So it's not so much the region; it's what's left. Can the reading frame be in there? And I regret we don't have it's the whiteboard or something to show for a podcast. But we often use the phrase "the big red dog ran and sat." If you think of that phrase, it's all three-letter words. If I take out the letters D, D, O, G, or the G, G, D, O, G, the big red, G, R, E, D, if you take out those letters, we shift the rating frame. But I can take out the letters next to it. It's a bigger deletion, but now it's the dog ran and sat, right? It's not exactly the same, but it's functional. And that's really analogous to this Duchenne Becker. And that reading frame rule, we call it, is really what holds up. It's got about a 95% predictive value in Duchenne. I want to point out that's not 100%. And one of the things I always encourage trainees to think about is whatever comes back on the genetic report, it might come back and say this mutation predicts Duchenne. If you have a child in front of you running up and down the hall at 10 years old, 12 years old, that's not Duchenne. So whatever the report says, you have to compare it to what's in front of you. And that's where the biopsies sometimes come and help to sort out what's going on. There are other rearrangements of it. And of course, I know I'm talking about, the minor exceptions, but it's really important to parents, and it's important as we think of these new next generation therapies.
That's actually perfect. And I am glad I asked. I thought at the first part, I was like, we're going to talk about gene therapy or genetics in a point that we actually asked the subspecialist to really try to interpret for us. But I think this provides us all a good understanding of, okay, it's a little bit more complicated. Always look at the clinical patient, but it is actually what is removed or what is deleted in that genetic testing. So let's take our patient here.
Yep.
We have the genetic tests that come back. We'll say it's report saying, hey, this is going to be most consistent with Duchenne's based on where that deletion is. We see a kid in front of us who's already seeing symptoms at age 4. So you say, hey, this is probably along those lines. And now we can start talking a little bit about counseling for the family, what our follow-ups are, and our therapies. So let's just start basic. And so you first get this you first get your genetic report back. You come and see the family. How do you counsel the parents on this diagnosis?
Well, it's that first visit back is always it's a long visit. It's an emotional visit for the family. There's a ton of information that families want to understand about it. There's a lot of information out there that most of it's good, but some of it is misleading and other things. So we spend a lot of time with that. And we always begin by making sure that they understand some things about the genetics and see a genetic counselor. That's the really critical part of it. I'll begin by saying we routinely try to understand whether mom is a carrier or not, because we talked a little about symptomatic carriers before. What I didn't mention was carrier moms have their own risk for cardiomyopathy. So we want to make sure that they're involved and they're screened for that as they go along, but also for family planning purposes. It's sadly, we sometimes see, in your story, the boy gets his diagnosis at 4. There's already 1 or 2 other brothers who've been born since then who may have the same syndrome. And we want to allow families to make choices about family planning we really begin by making sure that the genetic counselor answers all the questions that parents need to know, particularly because the more complex therapeutic decisions they're going to be making in the coming years are dependent on specific mutations and so on. And then we talk really about what's known, the mainstay of treatment and the data, the thing that's been shown to be helpful in study after study after study since the first publication in 1974 is corticosteroids. So the mainstay of treatment are corticosteroids for this. Typically, we treat with there's a couple of different choices now, an increasing number of choices out there. But if we think about prednisone as the mainstay of treatment, the first studies that showed this, actually it was a lecture in honor of an old mentor of mine who passed away a few years ago, Dan Drachman at Hopkins. And Dan published a paper in 1974. The first paper, it was Lancet, treating 14 boys with steroids. And great paper. It's a kind of clinical observation paper you can't do anymore. You can't get in Lancet with that anymore. But it was really a key observation saying, hey, this is something that needs exploration, and randomized blinded studies have to be done. Those were finally done about 15 years later and showed a benefit from being on steroids at significant side effects. Obviously, when we treat a boy for a lifetime with steroids, we have all of the problems that we're familiar with, the weight gain, Cushingoid face, over time, and osteoporosis, sugar, potential for glucose problems, and so on. But in spite of all of those things, we have clearly shown that you can add time of ambulation by 1 to 3 years, and probably longer depending when you start. When I trained years ago, even though I was at the place where the first steroids were given, we were giving them out as boys looked like they were about to lose ambulation, sort of as a last-ditch approach. Now we know, really, we should be starting children early. We routinely start children in their ages 3 or so, and we know that the longer you're on steroids, the more protective benefits you have. What's changed now is alternative approaches to steroids. So one way is to do what we do a lot of, is to give a weekend dosing regimen where we sort of give as much as you would get during the week and give it on the weekends, or some colleagues do that even more on the weekends. And we think that it has I'm going to say this is opinion, there's a couple of limited studies that suggest equivalence between the regimens, but many of us believe over time we see just the same protective effect with much lower side effect profile. And then there are other drugs as alternatives to prednisone. Deflazacort is now approved for the use of steroids. It's given also daily or weekend dosing. More recently, a new drug has just been approved called vamorolone that is marketed sort of as a non-steroid or a modified kind of steroid, and with a recent paper just approved suggesting a kind of comparable benefit with biomarkers suggesting better bone health. Regardless, I sort of consider steroids as the mainstay of therapy, and in your scenario, we'd say to the 4-year-old parent and his patients, we need you to get on some steroids. Study after study has shown some steroids is better than none, and the variation in regimens are worth consideration, but there's a couple choices out there. So that's the mainstay of treatment. At the same time, we start to think about screening. We screen cardiac to see what their heart status is. And we also know, generally in our clinic, we start to think about a couple of other things. By the time a boy is 4 or 5 years old, we want to do cognitive testing as they go into school. If they have cognitive difficulties, we want to be able to support them in their process in school and get the things they need for that. Not all boys need that, but we want to do that. We also sort of start paying attention to contractures. The toe walking that we see is really it's an adaptation in some ways to the sort of pelvic weakness, the tipping forward of the pelvis. We try to minimize it we don't put boys in braces while they're walking around. We do try to put them in nighttime splints early on so that they start to minimize the progression of those symptoms. We start that young, so they're kind of used to it. I will say not many boys keep that for 5 or 6 years. They start to kick it off after a while. So those are the things we do generally at the first visit. When we start steroids, we start them and say, we want to see you back in 3 months, whatever the regimen is. See how you're tolerating it. See, do you have behavioral disturbances on it? What do we do? How's your weight after 3 months? And we see you back again 3 months thereafter. Then we get into an every 6-month cadence or so, roughly speaking, to keep a close eye on side effect profiles, to really engage with families. I feel like I've been rambling a while, but that's sort of our first visits as we go about this.
Kevin, just to ask an expert opinion question while we have you in the room here. You said lots of clinics do different steroid regimens. I'm just curious of what your steroid regimen is.
Well, it varies a little bit. The way that I view this is the gold standard, to some extent. The most clinical trials really support the idea of daily steroids. When I started seeing patients, I was at the University of Utah years ago, and 25 or 30 years ago, I knew many moms whose brothers had been put on daily steroids. In the old days, we'd put somebody on steroids, say, come back in a year, and all of the side effects had generated. Their weight gain was excessive, these things. And I knew many parents did not want to go on daily steroids. So I cast about, talked to a lot of colleagues, and heard about my colleague who's now here at the University of, at NCH, Ann Connolly, really had been promoting the weekend dosing regimen and had early papers to support that. So I increasingly use almost all the boys, the younger boys, we offer them this weekend dosing. I use a summated weekly dose. The standard daily dose is 0.75 milligrams per kilogram. By times 7 days per week, that's 5.25 megs per kg per week. And I offer that divided into 2 doses on Saturday and Sunday. Particularly when a boy is young and gets started on these medications, it allows vertical growth, it allows height, it clearly has a benefit. I will say my colleague here, Dr. Connolly, has published data on twice that dose, really 10 mg per kg, and would argue if she were on here, she'd tell you that's the way to do it. And I respect that, and she's published a couple of papers on that, and I support it as well. But my kind of experience between Utah and here is I'm comfortable with that sort of summated weekly dose. We revisit it quite frequently, though. We say, is this the right dose for your child? Sometimes we change it. We have some parents who say, no, I really want to stick with a daily dose because that's what most of the papers have supported. So we accommodate that. But my practice is largely weekend dosing with some patients on the daily dosing.
Awesome. That's super helpful. Thank you.
Yeah.
Hey, Cribsiders listeners. Factor meals are back, and it's time to hear about the deal they have for you. Factor is ready to fuel you up for these warm summer days with their no prep, no mess meals. Meet your wellness goals in time for the school year thanks to the menu of chef-crafted meals with options like Calorie Smart, Protein Plus, and Keto. Factor's fresh, never frozen meals are dietitian approved and ready to eat in just 2 minutes. So no matter how busy you are, you'll always have time to enjoy nutritious, great tasting meals. Personally, I love the options. With 35 different meals and more than 60 add-ons, there is something for everyone. Time is our most valuable resource in medicine, and Factor prioritizes it. Factor meals are ready in 2 minutes, no shopping, prepping, cooking, or cleaning up. If you think this is for you, head to factormeals.com/Cribsiders50 and use code Cribsiders50 to get 50% off your first box, plus 20% off your next month. That's code Cribsiders50 at factormeals.com/Cribsiders50 to get 50% off your first box, plus 20% off your next month while your subscription is still active.
And so we've just reviewed this life-changing diagnosis. We're starting them on steroids. You're seeing them back in clinic 3 months to start, then space out to every 6 months. What other specialties are you referring them to after this initial diagnosis? You mentioned screening for heart disease. You mentioned getting lower leg braces. So who else are they going to start seeing pretty quickly after you diagnose them?
Right, cardiologists and pulmonary, those are the two big teams. I should say many clinics, ours included, we have a big multidisciplinary clinic where patients come for a 4-hour visit. And during that 4-hour visit, we cycle in cardiology, pulmonary, occupational therapy, physical therapy, nutrition, sometimes social work, sometimes GI, other things as they go along. And what's kind of interesting, this is a resource-intensive clinic. Really, boys don't need all of that care in their first years of diagnosis. They don't. For example, pulmonary changes, we do not see changes in forced vital capacity. As a rule, we don't see that till a boy is in a wheelchair. So we as boys get older, we want to shift them into this multidisciplinary clinic. Same with cardiac issues. We don't see those issues at 5 years that we might see at 8 or 9 when we need to see it. So in our practice, just as a matter of resource allocation, we sort of make a shift from our less multidisciplinary clinic where they see PT and me, and we have occasional referrals to cardiac, to where we shift over into the full multidisciplinary clinic where all of these things are brought to bear. And obviously, as a boy gets older, into becoming a young man, I'll say our current modes of care, including quite importantly improved cardiac care and improved pulmonary care, has added about a decade of life expectancy to people with Duchenne. So we increasingly see men in their 20s with Duchenne, sometimes even older. But that visit changes quite a bit. It changes from me spending a lot of time talking about genetic therapies in the younger years to people much more attention to cardiac and pulmonary care. And these multidisciplinary clinics, I think, are key to success and are available to most parents in most large cities. And clinicians should know we if they're not convenient, we often share care with a clinician. They come to see us once a year, and we work with a local pediatrician or local physician to sort of see them at the intervals, at 6-month intervals. We can manage quite good care in that fashion as we need to do it. So early on, the key parts are physical therapy, early cardiology screening, our attention to steroid use and other things. As time goes on, endocrine, pulmonary, occupational therapy, and seating clinics, those things increase in importance with it.
I just want to get into cardiopulmonary for a second, just to complete this as a piece. So we'll start with the cardiac component. We talked about the cardiomyopathy that come with it. You talked about the echocardiogram, and you also talked a little bit about ACE inhibitors earlier. Yeah. If you wouldn't mind just completing that thought and telling us a little bit about how often we should get that echo and when we start the ACE inhibitor, that would be awesome.
Well, so we try to have every boy screened by either an echocardiogram or cardiac MRI by age 5 as a baseline. I will tell you, this is another field where very good physicians with deep expertise in it might have some different opinions about exactly when to start cardioprotective medications. And that's not from ignorance of the data. I'm lucky here because we have this great cardiology team where they weigh in early and help guide this. Most of patients are going on an ACE inhibitor by the age of 8 as protective. There's some evidence that an alternative would be ARB inhibitors, or ARB drugs. And the other cardiac drug that many patients go on is because some boys begin to have some tachycardia, particularly as they get older, and in the wheelchair we see tachycardia come in. So many are on beta blockers, and there's some variation in when those might be started protectively. The aggressiveness of cardiac medications really is dependent in part upon what's seen and increasingly seen on cardiac MRI, how much fibrosis is seen. is there evidence of cardiac remodeling, and might be more aggressive with the ACE inhibitors, or, and actually I didn't mention eplerenone and spironolactone. Eplerenone now is increasingly used. So there's some, I would say, some subtlety to it, and some maybe disagreement about exactly the regimen to do it. The important thing, I think, is to be under care of a cardiologist who either knows about Duchenne dystrophy or is willing to think about these things and manage them as they develop.
And the follow-up question to that is, just for your angle, is there a component with the ACE or ARB that actually affects dystrophin in and of itself? Or is this what we use for essentially heart failure, which we can talk about on a different episode?
Yeah, it really doesn't seem to have anything related to dystrophin expression itself. Okay. It seems to affect remodeling in the heart, and the ARBs particularly might have an effect on fibrosis and as a pathogenic pathway.
Awesome. And before we get to the big meat of this puzzle, which is the gene therapy, just the last thing I want to talk about is the pulmonary component as well. So the pulmonary component you had mentioned earlier, it's the diaphragm is one of the muscles that will also run into issues later on. From a pulmonology standpoint, what are they doing for testing as they go through this puzzle and the natural history of this disease, and what treatments might they be starting?
So, well, first I'll say, even though we think of diaphragm all the time, as boys get older, with scoliosis, with other things, and the thoracic muscles of ventilation as well, all become involved. I will say that the biggest change, there's a great old paper I cited all the time. I'm sure there are better ones, but I'm stuck on the ones I read 10 years ago or something. There's a great old paper that from the Newcastle group, Newcastle, UK, that showed, with just the change of nocturnal ventilatory support, non-invasive ventilatory support, along with scoliosis surgery, adding, when appropriate, adding something on the order of a decade to life expectancy. Wow. Undoubtedly, the number one change we've made, the number one thing is non-invasive ventilatory support. And it's BiPAP that we use. So the pulmonologists in our clinic, we're very fortunate here at NCH and many other places have people who become sort of neuromuscular ventilatory specialists. We make sure that there's early screening for nighttime hypoventilation. Sleep studies are critical. So by the time a boy reaches a wheelchair in general, that's when we start to see these symptoms. We make sure that the interview always includes questions about morning headaches and interrupted sleep and many other things. And then screening sleep studies with a very low threshold of suspicion to do those. The standard are BiPAP use and cough assist use, and those two things alone have had this enormous impact on survival. One of the challenges, I think it's fair. I don't think my pulmonary colleagues would mind me saying, one of the challenges is getting a young man to agree to use a BiPAP device when they do it. But once they get it adjusted and fit, most of them will never give it up, And it clearly has an impact on morbidity and ultimately mortality as well. And then coupled with the idea of judicious use of scoliosis surgery in appropriate boys, we think it really has, those two things have a huge impact.
This is great. I feel like that's a great pearl. And so we've talked about, the high-dose steroids and using them on the weekends only, which is pretty fascinating. Looking at cardiac MRIs to measure fibrosis of heart involvement and some of the ACEs or ARBs to help with cardiac remodeling, and now non-invasive positive pressure ventilation and sleep studies and scoliosis testing for pulm and cough assist are all kind of a broad treatment of some of the different complications, which is fascinating. And one of the things that I know we want to talk about before we run out of time is gene therapy, is some of the treatments that are available now in the future, but really the future is now with some of these gene therapy treatments. And so I was hoping to see, could you talk a little bit about how gene therapy works? Are they effective? And
sure.
Tell us about gene therapy.
Well, so I want to broaden just a little bit to think, and the exciting news of gene therapy of the past year has been gene replacement therapy with viruses, and that's important, unequivocally important. But I'll point out that the first approved therapies were actually, we think of them as genetic therapies. They hark all the way back to Sam's earlier question about, and the discussion of in versus out of frame mutation. So I gave an example of an exon 50 deletion being associated with Duchenne. It turns out there are ways you can use medications to skip an adjacent exon. These are the exon skipping therapies. They're genetic therapies, but they're not viral gene therapy delivery. But they're worth considering for a couple of reasons. First, they're out there, and what they are is antisense oligofragments. If you think of those 79 exons across 2.4 megabases of the locus. When that's transcribed, the transcriptional set makes a single-stranded pre-messenger RNA that gets spliced together, right? That's what happens. And if you put in an antisense fragment that binds to that single-stranded pre-mRNA, you can hide the exon definition elements of individual exons that you target. In that case, you exclude the targeted exon from the messenger RNA. The trouble with this is it's not that efficient if you can't get lots of antisenses in there. And some of the ways you put antisenses are not necessarily stable and so forth. But there are 4 drugs that are approved that directed to exon 45 and exon 51 and exon 53 that have been approved on the basis of making some functional dystrophin. And these are given right now as weekly medications, weekly infusions. The data is not overwhelming with them, but clearly if these treat long enough with these classes of drugs, we can see boys differentiate from the untreated boys with the same genetic mutation. So it's only boys who were skipping of those individual exons would restore the reading frame. It's worth pointing out, though, there are ongoing trials, some of which we're doing here and others are doing around the country. They're trials of new ways to deliver these antisense oligonucleotides. So, for example, one of the most promising are a couple of different companies have conjugated these antisense oligos to an antibody or an antibody fragment directed to the transferrin receptor, which is on every cell, but it's super abundant in muscle. And it appears to be, at least in animal studies, that drags these antisense oligos into muscle and makes it way more efficient. So even though this is not a gene therapy, this is an exciting potential approach for those boys because the proteins that will be made from it are, in many examples, very functional proteins. We know that from Becker patients who were walking at 50 years old, for example. So that's kind of the first round of those approvals. For the first versions of those date back many years now, and the second generation ones are promising. So those are exon skipping drugs. We consider them genetic therapies, but not gene replacement therapies. What we think of mostly now as gene therapy, in common parlance, although I'll come back in a minute to other kinds of gene therapy, is gene replacements. The problem with this is we use this workhorse virus. Not a problem, the excitement about this. We use a workhorse virus called a family called adeno-associated virus. Adeno-associated viruses are not associated with disease. There's many different versions of these, different flavors of them, if you will. And what happens is they are gutted, so they cannot replicate in the body, and the payload then is a gene that you want to deliver. And the one that's approved now actually delivers a microdystrophin. It's a kind of that idea of in-frame taken to the extreme. Because you can only fit 5,000 nucleotides or so in one of these viruses, you have to cut bits out of this 11,500 cDNA. So you have an engineered protein that has these critical domains, to bind to actin, to bind to dystroglycan, portions of the rod domain, and so on. You can fit those 5,000 into the virus and deliver it to boys with Duchenne. And the first of these was approved last year. It was approved in June of last year. We're proud of it here. It was developed here at NCH, licensed to a company, to Sarepta, and further developed there, and received what's called accelerated approval. So it was approved for 4 and 5-year-olds. Did not receive full approval, but received for 4 and 5-year-olds, and we're using it in clinic now. And clearly there's kids who have benefit from this. It's public knowledge that the company is has before the FDA request to expand the label of that, and we'll know in the next month or so whether that happens. It's promising. We have some unanswered questions about it. How long will this benefit be there? We can't give it to everybody because adeno-associated viral antibodies are out. People who've been exposed in the environment to adeno-associated virus, they have antibodies and can't receive this therapy. Once we treat people with this, we immunize them. We get sky-high levels of antibodies. So today, at least, we can't retreat, although there are studies underway to try to knock down those antibody responses by plasmapheresis or other approaches.
So I just want to make sure I understand the microdystrophin piece. So it sounds like we're not actually working on the X, this large DMD on the X chromosome. We're actually just giving a fresh, new microdystrophin gene that we're just producing this separately to hopefully jump in and at least take the place of the dystrophin that was supposed to be produced on the X chromosome. Am I correct to that, or is it?
You're absolutely right. So, right, the AAV, we don't do anything to the chromosome with this, right? The chromosomal DNA. The AAV, when the viral genome is delivered, the viral capsid is sort of stripped away. That viral genome gets into the nucleus as what's called an episome. It sits there as its own separate little piece, and it's transcribed by a promoter that's in as part of the DNA. But you're absolutely right about describing what AAV does.
And does it go universally everywhere? So I would expect it to go everywhere, or just to striated muscle?
So the specificity of these treatments is dependent on a couple things. One, the short answer is no, it doesn't go just to striated muscle. The specificity is determined by the capsid. There's different versions of AAV, AAV9, AAVrh74, AAV6, AAV8, and different things. Some of those like muscle better. The second part of specificity is what promoter is on there. There are muscle-specific promoters that do it. So actually all these AAVs, they like to go to liver. Liver soaks up a ton of them, and much of what we worry about when we do these therapies is we worry about toxicity to the liver, acute toxicity to the liver. But the gene doesn't get turned on there because the promoter, the common promoters that are used with it, are only active in skeletal muscle. So we're not worried about dystrophin suddenly being expressed in liver. We are worried about the viral load. One of the biggest things in the field right now is really great scientists and great companies working on what are kind of liver detargeting things, that versions of engineered or evolutionarily directed, sort of directed evolution approaches to get to viruses that are much more targeted to liver relative to skeletal muscle rather than liver. So could you give 1/10 of the dose or 1/100th of the dose? We're giving trillions of particles when we give these things. Could we cut those things down and get less to the liver and more to muscle? It'd be cheaper, it'd be safer, and so forth. So that's where some of the things are headed. We might not be changing much about the microdystrophins themselves. We might be changing more the capsids in delivery in the coming years.
And I'm going to let everyone else ask questions in a second. Sorry, everyone, for hogging this, but I find this incredibly fascinating. The durability with which the research that was done, obviously it sounded like it was roughly expedited through the FDA. How many years at least did we have durability at the time of the last publication?
Well, the first patients were done, I think, are now at 6 years out. I should know that, Cole, but my colleague Jerry Mendel did the work here in the first publication. I think it was now 6 years old. But those were a handful of patients that were done. We're getting a better sense of durability now with the results of the randomized trials, which might show more variability in response to it. To the patients for a variety of reasons. So we don't have a sense. What we can say is AAV-delivered gene therapy directed, for example, to the liver in blood disorders and clotting disorders and other things, we can say that we do know that there's long-standing expression of more than a decade in examples where we can measure the markers of it. So probably the AAV genomes, the episomes that we deliver, we can anticipate that there would be long-standing expression from them. The kind of missing feature is if you give a boy a treatment and he goes out and starts running around and now his CK goes up and he's turning over muscle the way he shouldn't, it might be different. There might be different kinetics to it in muscle than in liver. We're going to see. We'll know this data in the real world sense in the coming years.
I mean, I think this is great. I think we've gotten to go through, a kid coming into the clinic with muscle weakness, talking about some of the initial studies from the 1974 Lancet case to now what's in the second wave of some of the gene replacement therapy. And so I think this has been wildly helpful, informative for all learners and listeners. Maybe you want to start wrapping up by saying, are there key take-home points that you want to make sure really get emphasized to listeners, or anything else that you think is important to share in the field of musculodystrophies for clinicians that might be seeing some of these patients?
Yeah, I guess the take-home points I'll mention again have a low threshold for ordering CK and even any developmental delay, speech delay, motor delay, or anything else, and make referrals to sort of expert centers where they can help design a program for parents. Parents are overwhelmed by this sort of news, and we spend many hours just talking to them about what's out there, what we can expect. One thing I'll say to pediatricians as they counsel patients about this, parents can find a lot of places where they say, you have to do this, you have to do that, or parent groups that say, oh my gosh, why aren't you doing this, or why aren't you doing that? I think they have to find clinicians who they trust and who trust them to report things back, and really find the right fit of these programs for them, being on some steroids, making sure that there's surveillance at regular intervals for heart. And, the other thing I often caution, them a little far afield here, so forgive me, but I often caution patients when they come in for the first time, there are real fraudulent things out there where people are targeting patients with promising, bring me a sack of money in Ukraine and I'll give you stem cells that'll fix everything. So it's worth clinicians to know that those kind of things exist. I know that's kind of obvious, but it's always in my first conversation with parents that we want to be the source of good information for them. So that's really a large part of what we do. Sorry, I think I took a right turn there at the end. So
no, it's also kind of like humanizing to remember, when the patients go home, what they're thinking and what they're doing. It's not just in the clinic about what the cardiac MRI says.
Yeah, I'm sorry. I didn't mean to interrupt you. I was just going to say one thing that is really true. When I started, I couldn't look any parent in the eye and said I knew there was something on the horizon that might be a benefit to them. That's not the case now. We know so much more just in general care. We have the first gene therapy approved for some subset of patients. We have lots of things in trials now that are likely to have really meaningful impacts on patients. They're not all going to land. They're not all going to get approved. But we haven't covered all of them. We've touched on many of them. But there are things out there. We can really look parents in the eye and say, who are getting diagnosed now, say, the newly diagnosed child course is not going to be the same as what's described in the textbook as 20 years ago. We have many other things. And I think we'll reach a state where we have this as a chronic treatable illness and then at some point a curable illness.
I think that's a beautiful note to end on. And so I'll transition to say, thank you again so much for your time, for your expertise, for sharing it with us and for our listeners. We really, really appreciate you coming on to the Cribsiders. So thank you so much.
Oh, it's been a great pleasure. Thank you very much for the invitation.
This has been another episode of the Cribsiders.
It's for the kids.
Get show notes and sign up for our weekly Knowledge Food Formula Feeds newsletter on our website at www.thecribsiders.com.
We're committed to providing you with high-value, practice-changing knowledge, and to do that, we need your feedback. So please subscribe, rate, review the show on Apple Podcasts, Spotify, Google Play, any of your podcast players. You can also send us an email at thecribsiders@gmail.com, and Sam will probably respond. A special thanks to our producer for this episode, Laura Lettingham, our showrunner, Sam Mazer, and our wonderful social media team on Twitter, Instagram, and Facebook. I've been Justin Lee Burke.
I've been Lauren Lettingham.
And I've been Sam Mazer. Thank you, and good night.